So as Carrie was saying, I'm a physician. My background is actually, I was trained as an obstetrician gynecologist, and then I did a fellowship in female pelvic medicine and reconstructive surgery. But about 7 or 8 years ago, actually it's been a little longer than that now, I got interested in lifestyle medicine. And it was essentially after reading a book called The China Study, which fundamentally changed the way that I thought about and practiced medicine. Because ultimately, all of the stuff that I started to learn, nobody taught me that in medical school. And my first reaction was that I was really ticked off because I spent a lot of money on medical school and a lot of time. But my second response was that I had to change the way that I was doing things. And so it started with us. It started with myself. It started with our own family, and we changed our diets. And today what I want to talk to you about is really using lifestyle medicine in both the prevention but also the treatment and reversal of type 2 diabetes. So let's see here if I can get this to work. Just as a show of hands also, RNs, nurse practitioners, DNPs, dietitians. Did I miss anybody? PA? Okay, great. Health promotions, perfect. Okay, super. So first I want to lay a little bit of groundwork about what lifestyle medicine is. As Carrie said, I'm both a fellow of the American College of Lifestyle Medicine, so I'm board certified in lifestyle medicine, but I'm also a member of the board of directors of the American College of Lifestyle Medicine. And the definition of lifestyle medicine is that it involves the use of evidence-based lifestyle therapeutic approaches such as predominantly whole food plant-based diets, exercise, sleep, stress management, alcohol moderation, and tobacco cessation, and other non-drug modalities to prevent, treat, and oftentimes reverse the lifestyle-related chronic disease that's all too prevalent. Because what we know is that fully 80% of the $3.5 trillion that we spend in this country on medical care is for chronic diseases that are primarily lifestyle related. So the vast majority of these chronic diseases are impacted by the feet, forks, and fingers. So feet, physical inactivity; forks, what we're electing to put into our mouths 3 times a day; and fingers, whether or not we choose to smoke. So there are other factors that impact our health, including sleep and stress and lack of intimate relationships in our life. But the Global Burden of Disease study, which was funded by the Bill and Melinda Gates Foundation, looked at chronic disease globally between 1990 and 2010. And what they found was that the United States, diet was the #1 cause of death and disability in the United States, and lack of physical activity was second. Or excuse me, smoking was second. So smoking causes about 450,000 deaths annually in this country, and dietary issues cause 700,000 deaths. So maybe you've heard about this, maybe you haven't, but if diet and smoking are the #1 and #2 causes of death and disability in this country, why are we still treating people with pills and procedures, right? And that's a great question. We're going to talk about how we got there in a minute. But before we do, I want to give you a few statistics. And you can read this slide as well as I can, but 14% of all U.S. adults are diabetic, 38% are pre-diabetic, 1 in 3 U.S. women will develop a life-threatening cancer in their lifetime, 1 in 2 men will develop a life-threatening cancer in their lifetime. 70% of all U.S. adults are either overweight or obese. Almost 70% of all U.S. deaths are the result of heart disease or cancer, and 40 to 60% of cancers are lifestyle related. Okay, so how do we get here? This doesn't show up real well, but so for the vast majority of human history, the #1 cause of death was infectious disease. So in 1900, 53% of all deaths were the result of infectious disease. But the advent of public health measures like water sanitation and vaccines and the advent of antibiotics led us to the 3% death rate from mortality rate from infectious disease now. And so the burden of chronic disease, it shifted toward a burden of chronic disease rather than infectious disease. But the other issue is that we have also shifted our dietary patterns. And historically, humans have lived in a state of scarcity, right? But as time progressed and we developed agriculture, the food supply became more abundant. And now there are so many calories that are available to people that we don't even know what to do with them all. And so as we've transitioned from a less labor-intensive economy to a more digital economy, we are less physically active. And so all of these things have resulted in us becoming overweight. It's predisposes to all of these other chronic diseases. And so what we're seeing then is this modernity, modern life is causing this epidemic rise in diseases like type 2 diabetes. So the incidence of type 2 diabetes has more than tripled to 20 million Americans since 1990. 1 in 3 Americans will be diabetic by 2050. And right now, again, as you saw on that last slide, 37% of all adults and 51% of all adults over the age of 65 have prediabetes. And there was a study that came out of the University of California, Los Angeles, that showed that 9% of the adults in California are diabetic, and 46% are pre-diabetic. So over half of the population in California is either diabetic or pre-diabetic. And I can tell you that our rates are probably worse here, right? Worse than they are in California. And what's really concerning about this is that also from the study, they found that 1/3 of the young adults between 18 and 39 were pre-diabetic. And all this is being driven by the rising prevalence of obesity that we'll be discussing here in a second. So while type 1 diabetes is still more common than type 2 diabetes in children and adolescents, the incidence of both is rising, but the incidence of type 2 is rising faster. And again, this is because of the parallel between diabetes and the obesity epidemics. And the percentage of the children in the United States with obesity has more than tripled since the 1970s. And today, about 1 in 5 school-age kids between the ages of 6 and 19 is obese. And between 1999 and 2008, the prevalence of prediabetes and diabetes in children increased significantly from 9% to 23%. So obesity is driving this train because of the hallmark of type 2 diabetes, which is insulin resistance. And insulin resistance is the result of the accumulation of intramyocellular fat. So fat that's accumulating inside the muscle cells. And this prevents the insulin receptors from functioning properly, gumming up the works, so to speak. So if glucose cannot enter the cell for utilization, then the blood glucose levels rise. And that's the hallmark of prediabetes or diabetes. So dietary fat, fat that's stored in the muscles, fat that's stored around your waist, all of that contributes to accumulation of this intramyocellular fat that's resulting in the type 2 diabetes. Oh, sorry. Okay, that's my little gummy lock there. Okay. And the mechanism by which this occurs, we know from certain studies. So they've done studies where they put people healthy young people in a lab overnight, and they infuse free fatty acids directly into the bloodstream. And what they see is that within 2 to 3 hours of the infusion of these fatty acids, they see a 30% reduction in glucose uptake into the cell. So that's effectively what's causing the problem. And conversely, if you take those same healthy subjects and then you infuse the fatty acids, but then you infuse a drug that's an anti-lipolytic drug, it actually then reverses the process. So after overnight, it reduces the insulin resistance by about 20%. And we've also got evidence from NMR spectroscopy that it's actually this intramyocellular fat that's causing the insulin resistance. So in effect, oh, here we go. Okay, so, and we know that excess body weight is the #1 risk factor for type 2 diabetes. And up to 90% of those who develop type 2 diabetes are overweight. So because the number of adipocytes are fat cells, the number of those fat cells does not increase as we get older. They just hypertrophy, they just grow. And those fatty acids then spill over into the bloodstream, get taken up by the muscle cells, and then causes the insulin resistance. So the reality is that sugar does not cause diabetes, fat causes diabetes. Okay, so the normal levels of free fatty acids in someone who is non-diabetic is about 1 to 500 micromoles per liter. But obese individuals and those individuals that are eating low-carb, high-fat diets, and even thin people with high-fat diets have free fatty acid levels in the plasma that are somewhere between 6 and 800 micromoles per liter. And even at the same weight, vegetarians have less than half of the risk of developing diabetes as an omnivore. So intramyocellular fat accumulation on biopsy correlates with insulin resistance, and vegetarians have less fat in their calf muscles than comparably slim omnivores. And this is because that different fats act differently in the body. So the saturated fat palmitic acid, which is found mainly in animal foods and palm oil, causes insulin resistance, while monounsaturated fats like oleate protect against something called fat-induced or saturated fat-induced lipotoxicity. And I don't know if you can see, but the vegetarian's on the top and the omnivores on the bottom. So lipotoxicity is the accumulation of fat in the pancreas. And this fat, when it accumulates in the pancreas, it induces the production of free radicals or reactive oxygen species that are damaging to the beta cells in the pancreas that produce insulin. And we know that if you decrease the amount of pancreatic fat, that the beta cells can sort of heal themselves. So autopsy studies have shown that by the time of diagnosis of type 2 diabetes, the beta cell numbers have decreased by about 50%. And this is important because we stop producing beta cells by the age of about 20. And then as time progresses, after about 10 years of having diabetes, the beta cell numbers decrease to about 20% of baseline. So the annualized conversion rate from prediabetes to diabetes is somewhere around 5 to 10%. But impaired glucose tolerance begins with this insulin resistance in the muscle. And we know that this can actually happen, even though the typical course of action is that it takes several years to do that conversion. If you do it in a lab, you can do it actually really fast. And so this was a study from, this is a historical study. This is from 1927. And what they did is they brought in young, healthy college students, and they fed them 4 different groups. They had 4 different groups, and they fed them all different diets. So there was a high-fat group, there was a high-protein group, there was a high-carb group, and there was a starvation group. And after 2 days, the starvation group and the high-fat group were diagnosed as diabetic, as with a glucose tolerance, a 2-hour glucose tolerance test of 170. The high-carb group was normal, and the high-protein group was borderline. So again, sugar doesn't cause diabetes, fat causes diabetes. And in vivo, what we see is that before type 2 diabetes is diagnosed, there's on average a 13-year period of abnormal glucose tolerance before overt diabetes is diagnosed. But that rapid increase from sort of impaired glucose tolerance to true hyperglycemia is about 2 years. Okay, so what do people with diabetes die from? They mostly don't die from diabetes. They die from heart disease primarily. About 75% of them die from heart disease. And they're also more likely to die at a younger age. Diabetics are 2 to 4 times more likely to have, diabetics are 4 times more likely to have heart disease, and they're 2 to 4 more times likely to die of a heart attack as non-diabetics, and they're 2 to 4 times more likely to have a stroke. And people with diabetes have the same cardiovascular event risk as someone who has already had a cardiovascular event. So diabetes is considered a cardiovascular, a coronary artery disease equivalent. And the mechanism for why diabetes causes these conditions is actually from these advanced glycation end products. So glycation, long-standing hyperglycemia causes this glycation. And what happens is that the glucose binds to these proteins and impacts the way that they function. So it impacts intracellular signaling, gene expression. It releases free radicals and pro-inflammatory molecules that contribute to the development of these diabetic complications and cellular aging. And advanced glycation end products have been found to play a role in the pathogenesis of many type 2 or many complications of diabetes, including retinopathy, cataracts, neuropathy, nephropathy, and cardiomyopathy. Erectile dysfunction. It's also important to note that the American Diabetes Association does not classify prediabetes as a clinical entity in and of itself. But that really should be reconsidered because we have a lot of evidence to show that the actual that there's damage from these glycation end products even in the pre-diabetic state. So there's damage to the nerves and the vessels even before diabetes is actually diagnosed. And all of these complications are well described in both type 1 diabetes and type 2 diabetes, with significant complications typically manifesting 15 to 20 years after diagnosis. But now we have to assess the way in which type 2 diabetes is impacting children and adolescents. Long-term outcome data is still pretty scant, but what we know is that the available literature suggests that the development of complications in youth with type 2 diabetes is maybe more rapid than in adults. And again, 30 years ago, virtually all type 2 or all diabetes in children was type 1. Type 2 was actually first described in 1980. And since the mid-1990s, there's been an increase in type 2 diabetes among kids as young as 8 developing the disease. And there was a 15-year follow-up study of some youth in Arkansas that were diagnosed with type 2 diabetes, and they found an alarming prevalence of blindness, amputation, kidney failure, and death by the time they had reached young adulthood. So in addition, youth with type 2 diabetes have a higher risk of any complication as compared to youth with type 1 diabetes. So the kids with type 2 actually have higher risks of diabetic complications than the kids with type 1. And the time to both renal and neurologic complication is significantly shorter for these kids with type 2. So while macrovascular complications are rare in young adulthood, microvascular complications and cardiovascular risk factors are highly prevalent. And the renal disease that's associated with youth onset type 2 diabetes is associated with end-stage renal disease in up to 50% of youth after 20 years with the disease. So preventing and reversing type 2 diabetes is dependent upon what changing what we're eating as Americans. So SAD, the standard American diet, which I call SAD, is 63% processed foods, which are high in fats, oils, sugars, and refined carbohydrates. 63% of our calories are coming from that. 25% of our calories are coming from animal foods, and 12% are coming from plant foods, but half of that is coming from nuts and candy bars and apples and pies. So there are two reasons why a diet based on processed food and animal foods is problematic. And the first is because of calorie density, which we'll talk about. And the second is because the actual composition of these foods. So calorie density. This is best described by a dietitian by the name of Jeff Novick, who is a plant-based dietitian. And we all, if you think about any food item, okay, and you look at foods based on how many calories they have in them per pound of food, okay, vegetables have about 100 calories a pound, so they're very low, calorie density, versus nuts are 2,800 calories a pound. And there's no argument that there are things about nuts that are probably beneficial for you, but they're certainly high in calorie density, so a little bit goes a long way. Oil and fats are 3,500 to 4,000 calories per pound, okay? And things like cheese can be as high as 1,800 calories per pound. Fruits is the second one, unprocessed complex carbohydrates, so that's oats and whole grains. Legumes are obviously beans, animal products. Processed complex carbohydrates are things like whole grain breads and pastas. And then, of course, you have your junk food, and then your nuts and seeds and your oils and fats. And what we know is that in order for us to feel full and satisfied, the average person, you need to eat about 3 pounds of food a day, because we have stretch receptors in our stomachs that tell us when we're done, right, when we're full. So if you eat a variety of foods from this chart, okay, and so you're eating whole grains, you're eating legumes, you're eating fruits and vegetables, and you add a little bit of seeds and nuts in there, and you eat 3 pounds of that a day, you're going to get about 1,350 calories a day, okay? Which, if everyone ate 1,350 calories a day, we wouldn't have anybody that was overweight or obese, right? Conversely, the average fast food meal has 836 calories, and that doesn't include the soda that goes with it. This is just the burger and the fries. So because of the high calorie density of foods that these foods contain, 3 meals a day of this is about 2,500 calories. Plus, that doesn't even include any snacks or drinks that people are adding. I mean, the Starbucks, we call them funny names in our house, but the fancy drinks, right? Some of those have as many as 900 calories in them. Well, you just need to exercise more, right? Good luck. So the truth is that if a pound of fat is 3,500 to 4,000 calories, that means you have to have a deficit of 3,500 to 4,000 calories a week in order to burn a pound of fat. Well, that means running on the treadmill 45 minutes a day at 10-mile-an-hour pace. Who does that? Not me. Or 5.5 hours of vigorous swimming, right? So this is pretty unrealistic for most people in general, and especially if you're starting from a place of being unfit and obese. Okay, so the second thing is, let's talk about composition. So not all calories are created equal. So 1 gram of fat is 9 calories, right, compared to a gram of carbohydrate, which is 4. But as we saw from the beta cell discussion, these fats act differently in the body. So we know that on average that those eating meat-free diets consume an average of 364 fewer calories a day, but they also have higher gene expression of a fat-burning enzyme called carnitine palmitoyltransferase that helps transport fat into the mitochondria for utilization as energy. And so it results in an 11% increase in the resting metabolic rate. And weight loss itself, we know, can reverse type 2 diabetes. But even just changing the composition of the diet to a whole foods, plant-based diet helps to lower glucose independent of weight loss. So in this study, what they did was they were able to demonstrate that they were able to demonstrate this because what they did was they took two groups of people, two groups of type 2 diabetics, and they put one on the standard ADA diet, and then they put the other on a whole food plant-based diet. And they made the people in the plant-based diet eat enough calories that they didn't lose any weight. And it was really a struggle for a lot of these people because they were eating plant-based diets, which are lower in calorie density, so they're having to shove so much food into their bodies, they were having a hard time eating it all. But they did it. And that what they found was that the plant-based diet group alone, without any weight loss, resulted in a 60% reduction in insulin requirements. And half of the participants no longer required any insulin at all after 16 days. And some of these people had been diabetic for more than 20 years. So in population studies, we know that plant-based diets result in lower rates of overweight and obesity. So this is from the Adventist Health Study. And so you can see the BMI for non-vegetarians, for semi-vegetarians, pesco-vegetarians, which eat fish, and then the lacto-ovo-vegetarians that are doing dairy and eggs versus the vegans that are eating completely plant-based. And the same holds true for diabetic risk. So you can see if the non-vegetarian group is the baseline, semi-vegetarians had a 28% lower risk. Pesco-vegetarians had a 51% lower risk. Lacto-ovo had a, I have to do the math, 61% lower risk. And then the vegans had a 78% lower risk of developing type 2 diabetes. And there was another study of Taiwanese vegans where they looked at, or there was vegans, vegetarians, and meat eaters. And so compared to the meat eaters, the male vegetarians had a 50% lower risk of developing type 2 diabetes, and the female vegetarians had a 75% lower risk. But when you looked at the vegans, there were no cases of type 2 diabetes. And when we look at plant-based diets as an intervention for diabetes, we see that plant-based diets can significantly improve psychological well-being, quality of life, control of type 2 diabetes measured by A1C, and other physical characteristics like weight loss, fasting blood sugar, total cholesterol, LDL cholesterol, triglycerides. But this is a really busy slide that basically shows that this was a meta-analysis of all of these diabetes trials with using diet. And in here, what we know is that the adherence was in 4 of the 9 studies, adherence was better for the plant-based group as compared to like an ADA diet or a Mediterranean diet. Plant-based eaters felt less restrained in those studies. In all 8 studies that reported baseline and end-line A1C levels, there was a greater reduction in A1C in the plant-based group. 5 studies showed significant weight loss in the plant-based group as compared to the other groups. 3 studies reported significant improvements in fasting blood sugars, and multiple studies have demonstrated that plant-based diets can significantly lower total cholesterol, LDL, triglycerides, and the overall risk for cardiovascular disease. So, plant-based diets are the clear winner. So, reversal of type 2 diabetes is possible in approximately 85% of all cases, and it's preventable nearly 100% of the time. But what about complications of diabetes? So what data supports treatment and reversal once complications have already occurred? So Neuropathy, diabetic neuropathy occurs in about half of diabetics, and there really are not any great medical therapies available. But there was a study published in 1994, and what they did was they put 21 diabetics who had been diabetic for up to 10 years in duration with the average age of 64, put them all on a whole food plant-based diet. And out of the 21, 17 had complete resolution of their pain, their neuropathic pain, within 4 to 16 days. Weight loss ranged from 9 to 20 pounds. 11 patients reduced their insulin requirements by 50% in 2 weeks. All participants were off hypoglycemic medications in 30 days. 80% reduction in antihypertensive medication requirement, and 71% of the participants were adherent 4 years post-trial. That's impressive. That is real impressive. And we think that the reason that this happens is that when the plant-based diet is started, it's clearing the small vessels and the capillaries of plaque and cholesterol that is disrupting the blood flow to the nerves. And so when the blood flow returns to the nerves, they wake up and get better. Okay, what about retinopathy? So retinopathy also happens to be reversible in some cases. And this was actually shown by Dr. Walter Kempner at Duke University. So Dr. Kempner was an interesting guy. This was back in the 1950s. And he was treating patients with malignant hypertension. And that was in the days before we had any really good blood pressure medications. And so he was treating them with rice and fruit. They were on the rice and fruit diet. So all they got was white rice and fruit. But he was really successful at reversing malignant hypertension with that. And he started doing other studies, and he looked at nephropathy, he looked at retinopathy. And he did a study. He took 44 patients with diabetic retinopathy, and 30 of them met criteria for retinitis proliferans, which was, so they had to have aneurysms, punctate, preretinal or vitreous hemorrhage, waxy exudates, neovascularization, and then again, 30 of them met the criteria for retinitis proliferans. So he put them on this rice and fruit diet for 22 months, and 13 of them had resolution of abnormal retinal findings in both eyes. 7 had resolution in one eye, and 15 had no change, and then 9 of them progressed. And he also saw a reversal of glomerular nephropathy in some of these patients. And again, super impressive. So conventional treatments, how am I doing on time here? Okay. Conventional treatments have relied primarily on medications. And even when patients have been referred for dietary counseling, the advice they receive is typically based on counting carbs, which is, as we know, since fat is what's causing diabetes, not sugar, then that's probably not the way we should be counseling patients. And many healthcare providers believe that better control of blood glucose equates to an improved long-range outcomes for patients, but the research does not bear that out, and actually has shown that aggressive blood glucose lowering with medications causes more harm than benefit. And so there were 3 landmark studies in 2008 that were published in the New England Journal of Medicine, and they all 3 revealed negative findings. So the ACCORD study was 10,000 diabetics into standard or intensive treatment groups. The intensive therapy group included up to 5 different classes of oral drugs with or without insulin. And the goal was to drive blood sugars consistently into the normal range. But it was found that the intensive therapy group actually had an increased mortality rate, and so they stopped the study prematurely. And the drug combinations may have actually been more dangerous than the high blood sugars they were trying to treat. Same thing with the ADVANCE study. It was another randomized trial of 10,000 patients, type 2 diabetes. They had 4 treatment groups. They had an intensive group with blood pressure lowering medications. They had a standard treatment with blood pressure lowering medications. They had intensive therapy without the blood pressure and a standard therapy without the blood pressure. And what they found was that there were no reduction in heart attacks, strokes, no reduction in deaths from cardiovascular causes, or reduction in death from any cause with the intensive therapy. And then the veterans trial, they looked at 1,791 military veterans to either get intensive or standard control. They were followed for 5.5 years. A1C levels in the intensive group went down to 6.9% compared to 8.4% in the standard group. But they also gained more weight in the intensive group, and there were more deaths in the intensive group. And sudden death, the risk of sudden death was 3 times higher. So because of an increased risk of cardiovascular events with some diabetic medications, the macrovascular benefits are now recognized as being absent. So what about microvascular benefits? This was a 2011 meta-analysis where they looked at that. And again, it showed that there were limited benefits in the intensive group. So they stated that they could not exclude a 9% reduction or a 19% increase in all-cause mortality and a 14% reduction or 43% increase in cardiovascular death. And the risk-benefit ratio of intensive glucose lowering in the prevention of macrovascular and microvascular events remains uncertain. But there is this harm from hypoglycemic events, which counteracts any benefit that you might actually get from these medications. So metformin specifically has been used for a long time. It's often considered first-line therapy. But again, this study showed, but this evidence that we have for it is typically based on a small study from the United Kingdom that was done in 1998. But again, they did another meta-analysis in 2012, and they came up with the conclusion that although metformin is considered the gold standard, its risk-benefit ratio also remains uncertain. We cannot exclude a 25% reduction or a 31% increase in all-cause mortality, and they were not able to exclude a 33% reduction or 64% increase in cardiovascular mortality. So again, more of the same. The glitazones, a study in 2001 on Avandia, 4 milligrams daily, twice daily, did decrease the A1C levels, but they had 66% more heart attacks and 39% more strokes and 20% more deaths. So the European Union said no more, and they got rid of it, but we still give it to people here for some reason. Sulfonylureas like glipizide and glyburide, these are secretagogues that increase insulin secretion by the beta cells, and they are considered second-line therapy. But there's been a long warnings associated with these medications because they increase the risk of cardiovascular deaths by 2.5 times compared to conventional treatment. Some of the new injectables like liraglutide or Victoza, what we know about this is that they do have in this study they had fewer cardiovascular deaths, so 1.2 cardiovascular deaths per 100 patient years compared to 1.6 for the placebo group. But ultimately, when you break it down, these improvements are sort of marginal because you have to treat 1,000 patients to prevent 4 cardiovascular deaths, and you have to treat 1,000 patients to prevent 4 cases of nephropathy. Aggressive blood glucose lowering and combination therapy has not been found to be beneficial, but individual therapies and medications, even when it's used in the right fashion, have their risks. Insulin has been shown to accelerate aging, promote obesity and atherosclerosis, stimulate cancer growth, and worsen diabetic retinopathy. And we know that gastric bypass is one of the most successful treatment methods for type 2 diabetes with long-term remission rates as high as 83%. But we can see the same thing happen with weight loss and acute. Anytime you do calorie restriction, you can see the same thing happen. And there are risks to gastric bypass surgery, especially in people who are morbidly obese, whereas the dietary therapies have no risks. So medications really do fail to significantly alter the course of diabetic complications. And ultimately, the treatment that's most effective and that can prevent these complications, as well as reverse the disease, is a whole foods, plant-based diet with other lifestyle changes. And this means elimination of animal products, elimination of oils, and highly refined carbohydrates. And as we said earlier, plant-based diets are low in calorie density, so they provide a way to help patients feel satisfied, but to keep the calories low. And reversal of the blood glucose levels to normal can happen within 7 to 14 days. So I'm going to run through just a few other specific foods that patients with type 2 diabetes should be also consuming in addition. So beans are really important. They have a low glycemic index. They're high in fiber, but they have this nifty little thing called the second meal effect. And they just including beans in the diet can lower the blood glucose as much as acarbose. But they also slow because they're high in fiber and they have this low glycemic index, they slow the absorption of blood glucose into the bloodstream. And so that's why you get this second meal effect. So beans at one meal can protect at the second meal, and it can actually even last for up to 72 hours. It can slow that absorption of glucose for up to 72 hours. That's more same thing. Indian gooseberries, or AMLA, has been shown to lower blood glucose, and you only need 3/4 of a teaspoon of this daily, and it's as effective as 5 milligrams of glyburide taken twice daily, and there are no side effects. AMLA has also been shown to lower LDL and triglycerides by half, or by 50%, and HDL has often increased on average from 49 milligrams to 83. The consumption of vinegar with meals has been used as folk medicine for a long time before there were any hypoglycemic medications, but it does actually work. And several studies have confirmed that in type 2 diabetics, if they take 30 milliliters of vinegar and 20 milliliters of water 5 minutes before a meal twice a day, they can lower their blood sugars as well as some oral hypoglycemics. Turmeric, curcumin is the active ingredient in turmeric, a yellow spice that's oftentimes found in curry. It's a potent antioxidant. And in 2012, they did a randomized placebo-controlled trial of curcumin, and the dose was 750 milligrams twice a day of the curcumin extracts twice a day. And it was able to prevent conversion of pre-diabetics to diabetics. So the placebo group had a 16% conversion rate in 9 months, whereas the curcumin group had no conversions in that 9-month period. Flaxseed is another, has also been shown to be beneficial. So 5 grams twice a day with meals they did a small placebo-controlled trial in 2011 for a month. And one group got supplementation and the other group got no supplementation. And in the supplementation group, they had a reduction in their fasting blood glucose by almost 20%, and reduction in their A1C by almost 15%, and a 14% reduction in cholesterol, a 17% reduction in triglyceride, and a 21% decrease in LDL. Oh, and chia seeds can do the same thing. Whole grains. Whole grains get a bad rap for some reason. I'm not exactly sure why. But they are so people who consume whole grains have a lower risk of developing type 2 diabetes. Now, white rice consumption has been associated with an increased risk of type 2 diabetes. But what we know is that those insulin spikes, those diabetes-inducing insulin spikes that you see after consuming something like white rice only happen in the context of animal protein consumed simultaneously. So if you just have a bowl of rice and beans, you get the bottom insulin spike. And if you eat a white rice with chicken or beef, you get the top spike. So the fat, the saturated fat that's in the meat, causes the insulin resistance that we see with infusion of those fatty acids. And so then it causes the white rice to cause that insulin spike. Same thing happens with juices, fruit juices. So they did a study where they looked at, if you consume berries at the same time that you consume other carbohydrates, it tends to mute that insulin spike. And they thought that, well, maybe it was the fiber that's in the berries, because berries tend to be high in fiber, but it's actually the polyphenols, because the same thing happens with juice. So if you give somebody blackcurrant juice or lingonberry juice at the same time as you give them this meal of high carbohydrates, you actually see a lower insulin spike than if you don't give that to them. And juice works just as well as the berries, interestingly. Okay, what about exercise? So exercise isn't great for losing large amounts of weight, but it does have an impact on glycemic control. So it does improve insulin resistance. So it can be as effective as some oral hypoglycemic medications. 150 minutes per week can reduce the A1C by 0.89 percentage points. So that means, going from an 8 to a 7.2 or 7.1. And 150 minutes of moderate intensity physical activity is all that's needed. So that's 30 minutes, 5 days a week. More has not been shown to be beneficial. And higher intensity does relate in greater reductions of the A1C. Okay. I don't know what time is, but 10 to, perfect. Okay. So thank you. I'd like to, any questions that people have, I'd be happy to answer. Yes?
When you have a short period of time to spend,
Yep.
and they're just not allowed to diagnose, they're upset,
Yep.
they ask thank you, what should I do, etc. What is the go-to pulse sentences you use to help them see improvements in a short time?
Yeah, so that's a, so the answer is that our system is not set up to do that, right? We all know it. And that's part of what I'm doing at Doan is I'm trying to help educate physicians about how to do those kinds of things specifically, practitioners, but also how to educate patients. So we're right now working, so the ideal situation would be you diagnose somebody with type 2 diabetes and you say, okay, what we need to do is, yes, this can be reversed, but it's going to require some work on your part in terms of changing, your diet and your lifestyle. And then here's the program that we're going to put you in that's going to help you do that and do it and like really do it, right? Not just, I'm not bagging on dietitians. I'm not bagging on anybody, okay? It's our system. This is the way this is set up. I would have a patient that was an OB patient, right? They failed their glucose tolerance test, type 2 diabetic. Okay, we gotta do something about this. You send them off to the dietitian. They get the typical, count your carbs, do this kind of thing, and they go home and they don't do any of it because there's no follow-up. I mean, we failed miserably for these people. So the best answer I can give you is, and we can talk more about it, is to work within your system to set up a place to have those people where they can go to get the proper education that they need. Because you can't do it in 12 sentences, right? You just can't, and you can't do it in 10 minutes. It takes tons of time, and it takes tons of hand-holding, and it takes tons of, they need peers that are going through the same thing that can help them as well. So I don't have a great answer for you, but I think there's some solutions out there.
Well, how come the American Diabetic Association hasn't caught up with this?
That's a good question. If you look at some of their sponsors, Coca-Cola, Kraft Foods, it's all about the Benjamins in this country, So we have a real problem with food producers having serious influence in healthcare, and that's a real problem. Yeah.
And where are some education, so say we wanted to, utilize this, where
Yeah.
can we refer the patients to get this kind of education?
Yes. So there are lots of programs out there. So actually, we're actually working on a patient education program right now. It's going to be an online course that they can take. But there's currently a program called CHIP, which is the Complete Health Improvement Program. It's something that you can bring into your organization. There are ways to get it paid for by insurance. I can help set those kinds of programs up for clinics or hospital systems or whatever. So otherwise, it's they're left to reading books and watching this documentary and that, and those things are good, but a lot of patients aren't going to sit down and read a book, cover to cover. And they need a lot of coaching, and they need a lot of, like I said, hand-holding. And I don't mean that in a derogatory way. We all need hand-holding at times. So there are some resources out there. And I've got I've got cards here. I'm happy to communicate with any of you about solutions that you can offer to patients, resources that you can offer to patients. There's a bazillion out there, and I'll try to point you in the right direction. So. So the American College of Lifestyle Medicine is an organization that encompasses physicians of all specialties, but we do have a relationship with the Endocrine Society, the endocrine physicians, and some of them are starting to adopt this. I'm doing another one of these talks in April, and I can't remember which one that one. I think it's cardiovascular disease. We're going to be talking about the same thing, but from the perspective of cardiovascular disease. And I work with a physician by the name of Dr. Esselstyn. He's at the Cleveland Clinic, and he has Prevent Reverse Heart Disease. And actually, the course that we're developing has a lot of his content in it. What did you ask me? I was telling you that for a reason.
Collaboration.
Oh, right, the collaboration. So, historically, like the American College of Cardiology has not, looked at any of this kind of thing. Well, now, their past president was Kim Williams, and he was plant-based, and now they have a American College of Cardiology nutrition committee that they just started a couple of years ago, and Dr. Esselstyn is now on that committee. Dr. Dean Ornish is on that committee. So it's coming. It's coming. They're just slow, right? Because the truth is that cardiovascular disease is big money in this country. I mean, bypass surgery is $500,000, right? So there hasn't. I mean, teaching people how to eat broccoli is like, you know what I mean? Like there's no big broccoli out there, and so we just don't have. We haven't historically had the kinds of resources, and we're fighting an uphill battle against a lot of entrenched interests. So that's why it's taking so long, but it is starting to happen. So, yeah.
Had somebody that wanted to read information on it? Do you have a recommendation on the first start where the beginner would?
Yeah. So for a practitioner or a patient, or both. So there are some really good diabetes books out there. Neil Barnard is a physician. He's with the Physicians Committee for Responsible Medicine. He has a book on type 2 diabetes reversal. I'd probably start there. He has some great online resources and videos for people too that I can point you in that direction. But I think I'd start with that one. Joel Furman also has a type 2 diabetes reversal book. Furman. Yes, thank you, Dr. Greger. Dr. Greger's my hero. So everyone write this down, nutritionfacts.org. Thank you. You can, short videos on any health topic that you can possibly imagine. So a lot of my information about when I find out about, I go look on his website for the studies on turmeric and AMLA and whatever else, and then I go back to the original papers and pull the information because he provides all of that information there. He's amazing. And his book is called How Not to Die. And he's very entertaining. But his book is called How Not to Die, and it's phenomenal. And that's a great resource. And so it goes through all these different disease processes. So that's a really good resource too. I also developed curriculum for Doan. So you can now get board certified in lifestyle medicine. RNs can get board certified, and nurse practitioners can also get board certified. And I have some information on that I can share with you. But in order to get board certified, you have to do 30 online continuing medical education credits in lifestyle medicine. And they have to be approved by the American Board of Lifestyle Medicine. So we have an online program that's approved. So if you're interested in this, you can learn more about all of these various topics, and you can work toward board certification.
Recipe ideas.
Yeah. So Forks Over Knives is a great place to start in terms of recipes. Dr. McDougall, John McDougall, is in Santa Rosa, California. They have a lot of recipes on their website. Dr. Esselstyn, and there's a lot of great cookbooks out there. So like there's Dr. Esselstyn's family has the Prevent and Reverse Heart Disease cookbook. Dr. Furman has an Eat to Live cookbook. But all of these cookbooks are, the food that's plant-based, meals with no oil.
Facebook groups too.
Tons.
The Works Over Nights has an app that has
Yeah, tons.
recipes, and you can like make your grocery list.
Yeah.
And Dr. Kroger has a Facebook page too, and he does a lot of videos.
He has a cookbook too. He has a How Not to Die cookbook. It's very, very nice. But there's a ton of them out there. Plant Pure Nation, China Study Cookbook, Engine 2. Yeah. Thank you. You guys have been a great group.